Well, all forms of vasculitis can give you petechiae and purpura because petechiae and purpura are non-blanching. Non-blanching lesions can be either breakdown of the blood vessel from low platelets and petechiae, or they can be inflammation and damage of the blood vessel from vasculitis. So all forms of vasculitis can give you anemia. They could be, particularly systemic vasculitis, or anemia of chronic disease. All forms of vasculitis can cause glomerular disease. They can cause mononeuritis multiplex as they involve the vasonervorum. So now you have to say what's different and unique about each of these. 67-year-old man is coming to the emergency department with jaw pain when eating. Jaw pain when eating. So he's got jaw claudication. Jaw claudication. And that's got jaw pain when eating because it's happening is it becomes like your thighs in peripheral arterial disease. They get exerted themselves, they use extra oxygen, and it becomes painful. There's tenderness when he combs his hair. This always happens to me, combing my hair. Well, for instance, for me, it's very easy because I'm combing the hair, the single one. So why tenderness when combing the hair? Because what other reason do you have to touch the side of your head where your temporal artery is? Now, temporal arteritis is a form of giant cell arteritis. And that's why you can also have stiffness over the hip and the shoulders, and the shoulders and the hip, and the hip and the shoulders, and shoulders and the hip. That's why the forms of giant cell arteritis can be both temporal arteritis and polymyalgia rheumatica, right? Ooh, dermatomyositis. Well, where's the skin lesions? Where's my Gotron's papules over the side of the back of the hands, below the back of the hands? Where's my heliotrope rash over my eyes and the face? Where's my shawl sign? Okay, over my chest. Oh, fibromyalgia. Well, fibromyalgia is straight on ahead pain without exactly weakness. It's straight on ahead pain and tender points, but you'd have to have multiple tender points. Also, fibromyalgia is better with exercise, and fibromyalgia will describe unrefreshing sleep. I went to sleep, I woke up in the morning, I was still tired. Unrefreshing sleep, treat it with exercise. Giant cell arteritis. Ooh, I think it must be that. I just said it. Or is it Lambert-Eaton? Well, Lambert-Eaton or Eaton-Lambert. Lambert-Eaton myasthenic syndrome is a form of weakness that gets better with repetitive use. A form of weakness that gets better with repetitive use. Myasthenia gravis doesn't have pain. It's straight on ahead weakness. So it wouldn't be jaw claudication. It'd be jaw weakness. So this specifically says jaw pain, whereas myasthenia gravis would be decreased ability to finish meals. So giant cell arteritis. Ooh, look at all these. Which of these tests? ANA is terribly nonspecific, and even here it's not a great initial test. Not a great initial test. Sedimentation rate, because sedimentation rate in this setting pretty much means that you have polymyalgia rheumatica, temporal arteritis. Now, here's the other precise way of saying C-ANCA, which is proteinase 3 ANCA. Proteinase 3 ANCA, the artist formerly known as C-ANCA, which is there in the artist formerly known as Wegener's granulomatosis. MPO means anti-myeloperoxidase or myeloperoxidase ANCA. So artist formerly known as P-ANCA. Who will get MPO? Myeloperoxidase ANCA is microscopic polyangiitis. Microscopic polyangiitis should be giving lung and kidney, lung and kidney, lung and kidney. Proteinase 3, lung and kidney, lung and kidney, lung and kidney, lung and kidney, lung and kidney. I see no lung nor no kidney in this disorder. There's our temporal artery. The most sensitive test? We don't even give you multiple choice because we know it's a biopsy. So how can we biopsy off the whole temporal artery? And the answer is because we don't need the temporal artery. Because we don't need it, you can biopsy and get rid of the whole temporal artery. Now, because this person has the findings of temporal arteritis, jaw claudication. Why? Because when I'm exerting our jaw, it gets hurting because I have vascular insufficiency. Tenderness over the temporal artery. High SED rate. I should not have to wait for the results of that biopsy. Give the steroids and wait for results of biopsy. Give the steroids, wait for results of biopsy later. How do you tell the difference between giant cell arteritis and polymyalgia rheumatica? Well, giant cell arteritis is going to be the one that gives you temporal artery problems and visual disturbance. The visual disturbance, you go blind. This is some of the easiest questions here. and stroke because it causes an inflammation of your brain. You see, the visual disturbance one is not going to be too hard a question for you, but knowing that it also causes a stroke. But they both get treated with steroids. And that's the difference. Now, polymyalgia rheumatica, how you're going to tell it apart is that also polymyalgia rheumatica is pain. It hurts. Shoulder and hip and limb and girdle and shoulder and hip and limb and girdle. It hurts, but when you touch the muscle, it's not tender. Polymyalgia rheumatica is pain. A normal person should be able to lift themselves out of a chair without using their arms. In other words, a normal person should be able to do this. I got out of this chair without having to use my arms. But a person with polymyalgia rheumatica can't do that. It goes, because we take for granted our ability to stand up. But this ability to stand up without using your arms is a much more complex muscular problem than you think. My abdominal muscles, my psoas muscles, leaning a little bit forward, then my thighs, then I come up. A person with polymyalgia rheumatica can't do it. They have to go like this and push themselves up out of the chair by using their arms. And that's how you'll recognize it. Cardiac complications is that people get aneurysms the same way that there's inflammation of this vessel. You have cardiac complications with an aneurysm. This is a man with fever and weight loss over the last several months. What's up in those fishnets? I'm not wearing fishnets, but it looks net-like. Yes, it does look net-like. He's got difficulty walking. He's tripping. He's falling. Why? Because he's got foot drop. Why has he got foot drop? Because that's part of vasculitis. When you have peroneal nerve involvement, you can get foot drop, tripping and falling because your foot is hitting your toes, hitting the ground over a couple of months. What's the abdominal pain after a meal? It's intestinal angina. It's intestinal angina. Vasculitis, intestinal angina. Vasculitis, intestinal angina. Vasculitis, foot drop, mononeuritis multiplex. Fever and weight loss. Every form of vasculitis can give you fever and weight loss. And what is here on the legs? It's livido reticularis, a net-like lividity of purplishness. Livido reticulitis. Mottled net-like rash is livido reticulitis. What's the significance of the injection drug use? The significance of the injection drug use. So gangrene of the big toe, right? Why? Because that's part of vasculitis. It damages the blood vessels. Foot drop, mononeuritis. You see how we have the nerves being seen here? And decreased pain, decreased strength and dorsiflexion. That's part of foot drop. That's peroneal nerve. Peroneal nerve. What's the significance of the injection drug use? The significance of the injection drug use is that it gives you hepatitis B and C. Well, Guillain-Barré is ascending weakness and a loss of reflexes. Ascending weakness and a loss of reflexes bilaterally. Reflex sympathetic dystrophy. You should see trauma, damaging a nerve, removing the myelin sheath, damaging the nerve with the myelin sheath with the reflex sympathetic dystrophy, and it can resorb a bone with the reflex sympathetic dystrophy. Mononeuritis multiplex is because the vasculitis is damaging the vasonervorum, and this can happen in response to polyarteritis nodosa. And polyarteritis nodosa, the significance of the injection drug use is polyarteritis nodosa is secondary to hepatitis B and C in about half the cases. So myeloperoxidase antibodies are negative for P-ANCA. Well, that's true because half of people just don't have a P-ANCA positive. The SED rate and C-reactive protein are elevated in a lot of people who have vasculitis. Now, giving people empiric steroids and cyclophosphamide in the response to empiric therapy is a terrible idea, and basically we are never going to give people empiric cyclophosphamide. Remember the intestinal angina? Well, doing a GI angiogram. Doing a GI angiogram and looking for these abnormal outpocketings, looking at a GI angiogram for these abnormal outpocketings of the blood vessels is a lot better than biopsying a kidney. Now, but Dr. Fisher, isn't a renal biopsy more sensitive and more specific than an angiogram? Yes, it's more sensitive, but you don't want to do a test like putting a needle into a high pressure system like your kidney, which you can't tamponade, when you could do a GI angiogram and spare yourself the kidney biopsy. Now, if the GI angiogram is not diagnostic, we still want to spare ourselves the kidney biopsy so we can do a sural nerve biopsy. Now, if I asked you where your sural nerve was before you saw this picture, 4 out of 5 people tend to not know where their sural nerve is. And that's a good thing, because if you knew where your sural nerve was on the back of your gastrocnemius, you wouldn't want it biopsied. You see, one of the things about doing a biopsy is, if you know where the organ is, you don't want it biopsy. Hi, I want to biopsy your eyeball. No. I want to biopsy your penis or your kidney. No, I know where those are. I don't want you taking a piece of it. I want to biopsy your sural nerve. Where's the sural nerve? Oh, it must be there. Well, I can't even see it and I don't even know what it does. Go ahead, take it. I don't need it. And you do biopsy the sural nerve because you're looking for vasculitis and inflammation of the vasonervorum. How do you differentiate between polyarteritis nodosa and microscopic polyangiitis? Polyarteritis nodosa and they both have GI problems because they're both vasculitis. They both give petechiae and purpura and petechia. They both give a high SED rate. They can both give anemia. They can both give kidney problems. They both give joint pains. They can both give kidney problems. Hematuria, proteinuria. But what the difference is? Lung involvement. Polyarteritis nodosa tends to spare the lungs. The significance of the injection drug use is that HIV does not cause polyarteritis nodosa. Staph toxin doesn't cause polyarteritis nodosa. It is because hepatitis B and C are underlying almost half of cases of polyarteritis nodosa. The same way hepatitis B and C can cause cirrhosis and can cause liver cancer. They're inflammatory, they're carcinogenic, they're inflammatory, the same way they're associated with vasculitis. Polyarteritis nodosa, steroids and cyclophosphamide, and we're not going to give cyclophosphamide to anybody. Chemotherapy, we're not giving chemotherapy to people who we don't have a biopsy on. What is this? This is vasculitic lesions, petechiae and purpura. 34-year-old woman, a rash and joint and abdominal pain. Urine look like tea or Coke. Tea, cola-colored urine. GI, joint, skin, and renal. GI pain, joint pain, skin rashes, and renal. GI, joint, skin, and renal. GI, joint, skin, and renal. Ooh, GI, joint, skin, and renal. They're non-blanching because they're vasculitides. If it was an allergic reaction and you pressed on them, they would turn white. These are non-blanching. These don't turn white. These are non-blanching and they don't turn white because the skin is broken down. So since the skin is broken down, inflamed vasculitis, they don't turn white. I got purple buttocks. You see the purple buttocks? I squeeze your buttocks and they don't turn white. GI, joint, skin, and renal. It is Hanoch-Schönlein purpura. Hanoch-Schönlein. GI, joint, skin, and renal is Hanoch-Schönlein purpura. And you'd first look at a urinalysis to look for hematuria, proteinuria, red cell cast, hematuria, proteinuria, red cell cast. The protein-creatinine ratio can spare you the need to do a 24-hour urine. Because if your protein-creatinine ratio is 3.5 to 1, your 24-hour urine will show 3.5 grams of protein per 24 hours. Anti-streptolysin O and double DNase, anti-hyaluronidase, ASLO, DNase, anti-hyaluronidase is for post-streptococcal glomerulonephritis. Anti-streptolysin O is too easy, but the anti-DNase, anti-hyaluronidase is the other test for post-streptococcal glomerulonephritis. Urinalysis is first. Now, it is cryoglobulin. What's the difference between cryoglobulin and a cold agglutinin? Cryoglobulin is a cause of vasculitis. Cryoglobulin is in response to hepatitis C. Cryoglobulin is a cause of renal failure, glomerulonephritis. Cold agglutinin disease is a form of hemolysis. Cryoglobulin and cold agglutinins are both IgMs. Neither respond to steroids, but cryoglobulin is kidney. Henoch-Schönlein purpura, GI, joint, skin, and renal. Post-strep glomerulonephritis does not give you the joint pain, does not give you the abdominal pain, the GI pain, and doesn't give you the skin lesions. Oh, systemic lupus. Oh, you know it can't be that. We already did the lupus case. IgA nephropathy is very similar to Henoch-Schönlein purpura. IgA nephropathy is very similar in terms of Henoch-Schönlein purpura and IgA nephropathy are both from IgA. But the difference is IgA nephropathy, the artist formerly known as Berger's disease or Berger's disease, Berger's disease, IgA nephropathy is IgA only in the kidney. IgA only in the kidney. Whereas Henoch-Schönlein purpura is the systemic vascularity mostly affecting GI, joint, skin, and renal. Henoch-Schönlein purpura is different than a typical vasculitis because it's not giving you the Henoch-Schönlein purpura, not giving you uveitis, not giving you mononeuritis multiplex. It's different because it's more limited, the Henoch-Schönlein. The most accurate test would be a biopsy of the skin or the kidney, but there's a difference between saying, what test would I do? I wouldn't do any test. Urinalysis, and that's it. Look for red cells, protein, red cell casts. I don't need to biopsy the skin or the kidney. I'm not biopsying the kidney. Why should I biopsy the kidney? Henoch-Schönlein purpura gets better in most people by itself. 90-95% of Henoch-Schönlein gets better by itself. Why should I biopsy little Johnny's purple ass or kidney? I shouldn't biopsy little Johnny's purple ass or kidney for a disease that gets better by itself 90-95% of the time. But what if I'm not certain of the diagnosis? What if I'm not sure if it's not polyarteritis nodosa? What if I have to think about steroids and cyclophosphamide, especially cyclophosphamide? What if they're not getting better? Then you better be sure what it is. What test am I going to do for this person? I'm not going to do any test. Urinalysis. What's the most common wrong answer? For IgA nephropathy and for Henoch-Schönlein, which is IgA deposited in the other organs, what's the most common wrong answer? The natural wrong answer is saying an IgA level. Of course it's a wrong answer. That's natural because it's IgA depositing places. Wouldn't you think there'd be an elevated IgA level? I would. It's just not helpful because it's normal in half of patients. So the most accurate is seeing the IgA deposited in places. And when do you answer that? When the disease is progressive. It's the 5 or 10% not getting better. The disease is progressive and the diagnosis is uncertain. It's not needed except if the disease is progressive or the diagnosis is uncertain. The treatment, ACE inhibitors, well, that's good for all proteinuria. Fish oil, that's nice, good for your breath. ARBs or ACE inhibitors, cyclophosphamide. Well, I'm not giving cyclophosphamide to people without a biopsy. The other thing is, didn't I just say that the majority of people with Henoch-Schönlein purpura get better on their own? Not only did I say it, it happens to be true. So don't do any treatment. It gets better on its own. Except sometimes it doesn't. 5 or 10% don't. Oh, protein creatinine ratio eliminates the need for 24-hour urine. Very few reasons to need 24-hour urine for a person just for proteinuria. 24-hour urine, hard to collect, not as accurate, lots of technical problems. Protein creatinine ratio. Uh-oh, now the protein creatinine ratio is 7-to-1. That means there's 7 grams of protein per 24 hours and the creatinine is rising. This person's getting worse. So we need to give some treatment. And giving Cyclophosphamide first, not good. But ACE inhibitor and steroids and maybe some fish oil. Fish oil is particularly for IgA nephropathy. So this is going to seem paradoxical. I'm going to tell you Hanoch, Schonlein, Purpura, and this is the problem with nephrology, right? Hanoch, Schonlein, Purpura. You don't need any specific test. What's the most specific test? Kidney and skin biopsy. Hanoch, Schonlein, Purpura. There is no therapy. What do you do for it? I don't give anything except if it gets worse. If it gets worse, I give these drugs, ACE inhibitors and steroids and maybe fish oil, even though they don't clearly work. What do you mean you're giving them if they don't clearly work? Well, because we try. And the answers would be the same with IgA nephropathy or Berger's disease. What reverses IgA nephropathy? Nothing. What's the most accurate test? Biopsy. Why do I have to biopsy IgA nephropathy? Because there's no characteristic skin or symptom pattern. Hanoch, Schonlein, Purpura. GI joint, skin and renal. GI joint, skin and renal. Nothing in the eye, nothing in the lung. I have a characteristic pattern. IgA nephropathy, no characteristic pattern. IgA nephropathy, no skin lesions to biopsy. That's why kidney biopsy is needed in Berger's or IgA nephropathy, but not needed in Hanoch, Schonlein unless the disease is progressive, the diagnosis is equivocal. What is effective? Nothing. What do you do? Fish oil. It's the paradox of nephrology. That's why people don't go into nephrology too much.